I'm Raghu Kolluri. I am the System Medical Director for Vascular Medicine at OhioHealth Riverside Methodist Hospital. I also am the Medical Director of the Syntropic Core Lab, in which this study was done, independently adjudicated. The study title is Restenosis after TAC implantation is associated with less complex patterns of restenosis compared to that of stent implantation. TACs are small implantable devices to treat dissections, and we also know that the TOBA 1, TOBA 2 results have been reported. The purpose of our study was to really assess, initially we wanted it to be sort of a descriptive study to see what happens in those patients who return for reinterventions and what are the patterns of restenosis or occlusion. And then it turned out that we wanted to look at, hey, compared to those patients who return having stents implanted as opposed to TACs, how do these restenosis or occlusion patterns fare to when compared to the stent population? So that was the study design and the premise and the reason the study was done. The patient population was the folks who actually had CDTLR, meaning reinterventions in the TOBA 2 population. And we, out of the 31 who returned for reinterventions, we had angiograms of 28 patients, 28 subjects, which were analyzed. Then we compared that to the Natascha criteria for in-stent restenosis. So it's a comparative study, right? So we're comparing the stenosis patterns and the TACs versus the stenosis patterns in the stents. So Natascha classification is basically class 1 is less than 5 millimeters, class 2 is more than 5 millimeters of stenosis, and class 3 is 100% stenosis. So we classified the TAC restenosis patterns and occlusion patterns similar to the restenosis patterns in our core lab, the Syntropic Core Lab. And then we looked at what the differences might be and how these two may differ. The results were interesting. When we looked at, so we wanted to look at patients at presenting, meaning, when they present for treatment for TACs and how they appear after they come back for the CDTLR, right? So when we looked at the baseline, there was not much difference between, the treatment patterns, the lesions that were treated, such as the diameter, the lesion length, the calcification amount, the dissections, the total number of TACs used, none of that was different. But when they returned, what we noted is that the restenosis was, mostly above the TAC or below the TAC, or if 2 TACs were used, sometimes in between the TACs too. So the restenosis patterns were somewhat instructive for us, if you would, that perhaps there are more dissections between these areas where these restenosis or occlusions occur. So when compared to the Natascha paper and the Aaron Armstrong's paper in terms of restenosis rates, CDTLR rates, as mentioned earlier, these rates in the stent groups, whether it's Natascha or Aaron Armstrong's paper, they were a third in each arm, meaning class 1, then class 2 was third, and class 3 was third. On the other hand, the TOBA group, when we compared it, most of them, 50% of them, were actually in class 1, meaning when these patients are returning, their stenosis lesions are much smaller compared to those with class 2 and class 3. So class 2 and class 3 were 17% and 32%. And the other thing that we noted was that in the Natascha group, the longer the lesion length, meaning the higher the class of restenosis, the longer the stent required. On the other hand, this was not the case with the tacks. The number of tacks that were placed in these patients and the tack to lesion length was pretty similar in all three groups. So basically, to summarize, first off, we wanted to kind of prognosticate and describe the results, if you would, in patients who are coming back with the restenosis once they're treated with these tacks. And what we noted is that these patients are returning primarily with a smaller lesions than when compared to these stents. Smaller and shorter lesions. The take-home messages really are in appropriate situations, obviously. When you use tags, you know that when these patients are coming back, their stenosis patterns are going to be shorter lesions, those class 1 lesions, and the total number of tacks and the metal implanted in these patients is going to be lower than those who have been stented. Now, looking at the stenosis patterns, when I note that the stenosis rates and the occlusion rates at the tack site itself is remarkably low, and what we see is above or below, perhaps another thing one would consider is to look carefully for residual dissections once the tacks are implanted to make sure that all of the ones above and below and between, all of the dissections are carefully taken care of. Well, hopefully, with the FDA approval, we'll see more data in this, more post-market and real-world applications and reports. So I'm eager to see how this plays into the big picture of endovascular revascularization.